All right, so we'll get started. Um, so how I'm going to do this is I have a PowerPoint that kind of goes over the procedure and some of my results so far. But I'll just kind of start it off with a little introduction. As I was introduced, I'm a board certified plastic and reconstructive surgeon. I specialize in microsurgery and peripheral nerve procedures. And this particular procedure that we're going to talk about tonight has been in the works since 2018. It is a procedure that myself and my partner developed, and we're really excited to share the results as it's picking up the ground off the ground, and we're getting great results with patients. But to start off with, erectile dysfunction is a complex process. It involves multiple different parts of the body to be in concert together at the same time for this to work. It requires your mental state, correct hormone levels, nerves working well, good vascularity, a spinal cord that's intact with a reflex arc to the spinal cord. So all of these things have to be in concert working for you to get an erection. And if any one of these are off, it can cause you to not get an erection. For example, if you're running down the street from a bear, you're not going to get an erection because the psychogenic component will override everything else. And likewise, if you have an injury to the nerve that connects to the penis, called the cavernous nerve, again, you're not going to be able to get an erection. My program is specifically designed to target and treat just one of the many categories of erectile dysfunction, and that's neurogenic erectile dysfunction. So that means nerve-related cause of erectile dysfunction. So I'm trying to answer this one piece of the puzzle to this complex problem. And I think it's a problem that's been neglected for a long time because, to be honest, urologists don't know a whole lot about nerves, and peripheral nerve surgeons, namely plastic surgeons, don't know a whole lot about urology. So there tends to be kind of a gray area here in our medical field where it gets a little neglected. And for a long time, men have been told, "Oh, it's in your head. You don't have a problem," and don't get a real option in terms of correcting the issue. So what we hope to bring to light here at the Institute for Advanced Reconstruction is a novel solution for nerve-related causes of erectile dysfunction. Okay, so that's just kind of the background. Let me start the PowerPoint. At any time, if anyone has a question, feel free to interrupt and ask a question. I don't mind at all. I want this to be kind of a casual discussion. So we'll just kind of take it step by step, okay? So here is my PowerPoint. All right. So as I was mentioning, male sexual arousal is a complex process. It involves psychogenic, which is the mind, hormonogenic, which is hormones, reflexogenic, there's a reflex arc to the spine, vasculogenic, which is the blood supply, and neurogenic process. We perform a novel technique of genitofemoral nerve transfer to restore cavernous nerve function in patients with neurogenic causes of erectile dysfunction. So the cavernous nerve is the nerve that causes erections, okay? So specifically the genitofemoral nerve, that's the nerve that I'm using to fix the cavernous nerve. The general branch of the genitofemoral nerve we chose as an ideal donor because of a couple of things. One, it's in close proximity to the cavernous nerve, so it's nearby. Also, importantly, it's a mixed autonomic and sensory function. So that's actually very novel that we're doing an autonomic nerve transfer. So we're taking one type of nerve, which is autonomic, and connecting it to another type of nerve, also autonomic. So in our body, we have three types of nerves. We have sensory nerves, which is what we use to feel something. We have motor nerves, which are for our muscles. And then the third type of nerve is autonomic nerves. And autonomics are in the background. It's like our heart, our intestinal tract, our breathing. and even erections. They're all things which we can't really control with our mind. Maybe we can adjust it a little bit, but for the most part, these are things that are working automatically. And so, as opposed to some other techniques that are being tried in other parts of the world, where they're taking a motor nerve and connecting it to the cavernous nerve, to me, this makes the most sense because it's like to like. We're taking an autonomic nerve and transferring it to a cavernous nerve. And then also important in terms of the nerve transfer is that it's a synergistic function with the cremasteric reflex. So what that means is that, so first of all, a cremasteric reflex, you might not have heard of that, but I'm sure you guys are all familiar. It's where you either are exercising or you get into cold water, maybe a cold shower or a pool, and what happens to your scrotum? It pulls up high and tight. That's the cremasteric reflex. It's an old protective reflex for the scrotum. So anyways, that same thing happens when you're having sex. So that makes for a good type of nerve transfer because that nerve, the genitofemoral nerve, is already firing when you're having sex. And so that's the type of nerve we want for a transfer. Now, nerve transfers is not novel. That we do those all the time. We do it in the arms, we do it in the leg. It's a way of bypassing an injured nerve, one that we can't fix for whatever reason. So it's kind of like if you're lighting up your Christmas tree and there's one bulb, like the old style lights, there's one bulb that's out and then the whole rest of the tree isn't lighting up. Instead of trying to figure out what bulb it is that's causing the problem, you take an extension cord and bypass that segment of lights and light up the rest of the tree. That's how a nerve transfer works, is that we take a functional nerve, cut one end of it, and then move it over to connect to the injured nerve and bypass an injured segment. And for most of my patients, the injured segment is inside the pelvis. So a lot of my patients have like a prostate surgery or prostate radiation or prostate removal, even prostate biopsy. Because the reason why I'm looking at those patients is because the cavernous nerves are immediately adjacent right underneath the prostate. And so they're easily injured during a prostatectomy or any type of prostate procedure. Here's a picture showing a lot here, but it's showing a couple different things. The upper red arrow is showing the cavernous nerve, and you can see it's coming right underneath the prostate and going into the base of the penis there. It also, there's some overlap with another nerve called the pudendal nerve, which gives sensation to the penis. And both nerves play an important role in getting an erection. The cavernous nerve actually gives the erection, but if there's an injury to the pudendal nerve, that can cause a misfiring in that reflex arc to the spine, causing a reflexogenic type of erectile dysfunction. So I see both types of patients, and we have different maneuvers depending on where the problem is, whether it's a pudendal problem or a cavernous nerve problem. But for tonight's talk, we're mostly talking about cavernous nerve problems. So the cavernous nerve is responsible for erectile function, and how it does that is it regulates the inflow and the outflow of blood in the penis. There's no bone in the penis. There's no muscle per se in the penis. It is a vascular organ, right? So it's like a balloon that fills up and then it deflates after ejaculation. Now, how it fills up and deflates is through the cavernous nerve. The cavernous nerve controls the gates of the blood flow in and out of the penis. So when you're getting an erection, two things happen. The in gate, which is the arterial gate, opens, allowing blood to come into the penis. And then the outflow gate, which is for the vein, that closes. And that allows the penis to engorge and fill and become hard. After ejaculation or climax, the opposite happens. The artery gate closes and the venous gate opens to allow the penis to detumesce or deflate. So those two things need to be working, and those are both controlled by the cavernous nerve. This cavernous nerve is easily injured, like I mentioned, with prostate procedures, and historically no improvement with nerve grafting. Nerve grafting is different than a nerve transfer. Nerve grafting is where a nerve is taken from another part of the body, say the leg, and cut on both sides, and then that little segment of nerve is brought up to, say, in the pelvis to replace a segment of the cavernous nerve. You would think that would work, but the results are pretty poor and really no improvement with that type of procedure, even when it's done at the time of the prostatectomy. it's a tough area in the base of the penis. I think it's tough, sorry, in the base of the pelvis. It's a tough area technically for the surgeon to operate, and these nerves are so wispy in that area. It just takes a little bit of pressure, and that causes the nerve to be dysfunctional, like someone stepping on a garden hose. Also important about the cavernous nerve is that it has a shared plexus with the dorsal sensory nerve, which is that pudendal nerve that I mentioned before. So in terms of candidates for this procedure, I'm mostly looking for patients who have had a known injury to the cavernous nerve. So prostatectomy, which is a prostate removal, prostate biopsy, prostate radiation, or also pelvic trauma. In addition, I've operated on 2 patients with diabetes. Diabetics have generalized problems with the nerves, and I'll share that data in a little bit. In terms of the candidate selection, there's a couple other things I do. So I want to, as much as I can, have a patient whose only problem is a nerve issue causing erectile dysfunction. So that means I screen and make sure patients don't have other issues such as vascular disease. That's ruled out simply with a penile duplex, which is an ultrasound of the penis. So an injection with Caberjet is injected into the penis, and we get an ultrasound to look at the inflow and outflow velocity of the blood to the penis. Also, some other preoperative things we do is we test for some different hormone levels, namely testosterone, but some other hormone levels like LH and FSH. I want to make sure the patient has an intact premasteric reflex, right? Because that's the nerve that we're using to fix the cavernous nerve, is the one that causes that premasteric reflex, which is the genital femoral nerve. Smokers are not allowed in the study, and no penile fibrosis allows for a candidate to be in this procedure, okay? In terms of the design, this is designed by myself and my partner, Dr. Elkwood. In 2017, we did multiple cadaver studies to confirm the feasibility of doing this, just to make sure this could actually work. What's novel also about this procedure and great in terms of recovery, in terms of complications, is that it's an extra pelvic approach. That means I'm doing it from outside the pelvis. I'm not going inside the abdomen, inside the pelvis. It's all on the outside, maybe an inch or 2 below the skin in the pubic hair area. I'll show some pictures of where the incisions are. And then in terms of the connection, I do an into-side neurotization, which means that I connect the genital femoral nerve to the side of the cavernous nerve, so kind of like a T. And when I do that purposely, in case there's any trickle of information going down the cavernous nerve still, I want to keep that open and not cause a problem there. So for methodology of how I'm evaluating the patients, there's a standardized questionnaire, 25 points that we do, called the Index for Erectile Function. Also, I have the patients give a log of nocturnal erections, morning erections, spontaneous erections, chemically induced erections, say with like Viagra or Cialis. And then I also have a grading scale of 0 to 10, judging the degree of the erection, which I use predominantly as my main criteria, with 0 being no erection and 10 being the erection of a 20-year-old guy, and then 6 being just enough erection for penetration. So that's the scale that I use. In terms of evaluation, besides the preoperative testing, I also require my patients to get a repeat penile duplex, that ultrasound, 1 year after surgery to evaluate the pre-op versus the 1 year post-op for the surgery. To confirm that I've actually found the nerve and that we have the right nerve, I use intraoperative EMG. So that means I have a nerve monitoring team in the operating room, and I have needles in the field and stimulators, and I can see the cremaster muscle with my eyes, and I put the needles in that. And then when I see what looks to be the genital femoral nerve, I test it by stimulating it, and my nerve monitoring team in the room can confirm and say, yep, you have the appropriate waveform, that's the right nerve. And likewise, I do a similar type of approach to differentiate the cavernous nerve from the dorsal penile nerve, which is a sensory nerve on the top of the penis. So I use that as, and it's a real big help to really confirm which nerves are there. And an interesting part of this program, because no one has done this type of intraoperative ENG before, all the textbooks, every single one shows that there's only one branch of the general femoral nerve on each side of the scrotum. But what I've found and proven is that on every single patient, and I've done 20 so far, that there is at least 2 on either side and as many as 4 on either side. And I can prove that with my intraoperative EMG. So whatever nerve I find, whether it's 2 or 3 or 4, I transfer all of them. I transfer as much as I can to give as much juice to the cavernous nerve as possible. Here's a little diagram to kind of show that nerve transfer in a simplified form, taking the general femoral nerve and moving it over to the penis to connect to the cavernous nerve. How that connects there is through a subcutaneous tunnel deep in the pubic hair. So you see here that the 2 little curved markings to the upper left and upper right, those are marking the inguinal canal. And then the other marks, the one at the top of the penis, that's one of the incisions. And on each side of the penis, there is another incision. So it's 3 incisions that I make, and this gives me the access to the complete area. So now this is looking inside. You see the green and black wires. That's my intraoperative EMG. So those are in the muscle, the cremaster muscle that goes around the testy. And then I've used that to find a nerve in the red loop there. That is one of the general femoral nerves. So I've isolated that and I found that. And then with the yellow loop up towards the top, that is a second general femoral nerve that we're looking at. And see in this picture, there's 3 that have been found all together on this side of the scrotum. And now looking, this is kind of a deep hole. This is at the top of the penis. Towards the upper part of the screen is the abdomen, and towards the lower part of the screen with that metal retractor, that's the penis. And what's around those 2 little hooks there, that is the cavernous nerve. So this is a tough part of the procedure because I'm working deep in a hole through a tiny incision. It's pretty hard to get there, but we have the technology with microscopes and small instruments that I can get into that space and perform the operation. It's another view looking at the cavernous nerves deep in that space. And this is after the procedure is done. All the incisions are closed up with dissolvable sutures, and some surgical glue is placed on all the incisions, and the patient can shower afterwards right away. All right, in terms of outcomes, so like I mentioned, I've done 20 procedures so far between 2018 to 2024. One patient was lost to follow-up, so I don't have data on him. And then there's 2 other procedures that were performed recently within the last 6 months, so I don't have their final outcomes. They're both doing well, but it's too early to give a definitive report on them. So just talking about the remaining 17 patients that I've done, overall it's an 82% success rate looking at all 17 patients. Now, how do I define success? I define success as getting, with the operation alone, getting an erection just enough for penetration. That's 6 out of 10. Now, it's not a great erection, right? It's kind of a soft hard-on, but it is enough just to get the job done. Now, of course, we would all want a 10 out of 10 erection. My usual story of successful patients is that prior to surgery, without medication, they were a 0 or a 1 in terms of erection. And then after surgery, I can get them up to a 6 or 7 out of 10 with just the surgery alone, without any medication. And then if they were to take Viagra or Cialis or even an injection with Trimex after the surgery, they can get up to a 9 or 10 out of 10. So that's my usual success story. I would have hoped that just with the surgery alone, it would be a 10 out of 10. We're not quite there yet, but in terms of the procedure being successful, it has been successful and really improved some of these guys' lives. Some of my patients hadn't had an erection for 15 years. And then with this procedure, they're able to get erections again. So it's been really great. If you see in this little pie graph here, I kind of divided it up into the types of etiologies. So patients with diabetes, there's been 2 of them. Only one of those worked so far. It's not to say, that with only 2 patients in that category, it's hard to say anything. I need more patients to be able to say anything definitive. And that really is true about this whole study. With so few operations performed, over 20, it's hard to give a real prediction about what the next surgery will be. If I have done like 500 surgeries, then I can give a more accurate prediction of the success or not. But this is, I'll try and be as transparent as possible, and this is the data I have so far. For my pelvic trauma patients, those patients have all done great. So all 4 of them had a success. The prostatitis patients, those are from, all 3 were from just a biopsy that got performed, and then they got a raging infection with prostatitis. All 3 of them were successful. For the prostatectomy group, 75% were successful of those 8. And then in terms of the penile duplex, my original plan was to only operate on patients who had a completely normal penile duplex, normal inflow and normal outflow. But what I was finding is that the majority of these patients have some type of vascular issue on their duplex. And it got me thinking about the vascular aspect of this, because these are patients that prior to the prostatectomy, for example, had perfectly normal erections, no issue at all, never had to take Viagra, never had any kind of problem at all. And then like a light switch, they got a prostatectomy and they weren't able to get an erection at all. So then when I evaluate them and say a lot of these patients had venous insufficiency, which means that the penis is leaving, sorry, the blood is leaving the penis prematurely, which means the blood's coming in and then going right out. And when that happens, you don't get an erection. The blood flow is controlled by these cavernous nerves. So to me, it makes sense that if the cavernous nerve is injured, we're going to see some type of vascular change. And so I began to operate on patients with mild venous insufficiency. And some interesting outcomes came from that is that when I repeated the 1-year duplex 1 year later, the majority of those patients with venous insufficiency, well, guess what? The venous insufficiency resolved. They had a normal duplex 1 year later, which is a pretty fascinating part, at least for me. It's a pretty fascinating part of this whole study is just to help explain how the system works in terms of the nerves controlling the inflow and outflow of the penis. So looking at this, just looking at the penile duplex, so the patients with a normal preoperative duplex, all 5 of them had a great success. The patients with venous insufficiency preoperatively also did pretty well, 82% success. The one patient I had that had both a venous and arterial insufficiency did not work. And then I do have one patient that I operated on recently with only an arterial insufficiency, but he's one of the patients that is within the last 6 months. So I don't really have data in terms of whether it's successful or not. And then in conclusion, so correction of neurogenic causes of erectile dysfunction is possible by utilizing a genital femoral nerve transfer to the cavernous nerve. And I demonstrated that through an improved International Index of Erectile Function scores, subjective reports from the patients, as well as improved penile duplex studies. So my early data shows 82% success. And then super interesting, at least for me, is that the reversal of this venous insufficiency may be possible with genital femoral nerve transfer. All right, so that's it for my presentation. And I'd like to open it up for anybody who has any questions.
Received one question.
Yeah, I see one question here in the chat. So is the P shot a good treatment for patients post-surgery? To be honest, I'm not sure what you mean by the P shot. If you're referring to like a Trimix injection, it is good to get injections after the surgery. It is good to take pills after the surgery, basically for my post-operative therapy, if you will. Of course, after the patient is healed, they're sore for maybe about 2 weeks or so. Oh, PRP for erectile dysfunction. Thank you for correcting that. There's not great science on that on this particular topic for erectile dysfunction. However, there is good science on other areas with PRP. And I did a lot of stem cell research when I was at Pittsburgh. And like PRP, there's which is taking the patient's own blood, spinning it down, and then doing an injection with the idea that you are purposefully injecting some stem cells into the area. It's not quite as good in terms of concept as if you were to say, take stem cells out of your bone marrow or isolate it from your fat, and which is generally not allowed in the US. But PRP is allowed. I think there's some good theory for it, and I think it could potentially help. Just hasn't been proven to help yet. I wouldn't be opposed to it if someone wanted to.
We received another question that asks, how do I know if my ED is nerve related?
Oh yeah, that's a great question. So there is no specific test to identify, oh, you have a cavernous nerve injury. So it's not like we send you for a blood test or an MRI or things like that. So with this, to say a patient has nerve-related cause, I essentially have to rule out all the other causes. So psychogenic, reflexogenic, vasculogenic, hormonogenic. So that can be done with a combination of blood tests and ultrasound, physical exam, and also just kind of talking to the patient. Pretty quickly I can kind of tell from a patient if it's a psychogenic issue or not. So it's ruling out all the other causes. I have had a couple patients where we've done a couple more studies just to kind of get some more information. There's a type of EMG that tests the bulbar cavernosus reflex. It's a pretty super uncomfortable to do. You have to put a pad on your penis and needles in the anus, and it sends electricity through there to look at the speed. So I don't make my patients go through that just because it sounds like torture. But that would be something if we needed additional data that could give some additional data. But generally, from just ruling out the other types of causes is how we figure that out. I see another question here. What is the recovery time after surgery, and how long do you have to take off time from work? And have you experimented with stem cells as you're constantly developing this procedure? Those are great questions. So in terms of recovery, you would think, at least I thought, that this would be a very painful procedure. It's really not. Most patients don't even take any pain medicine. They're able to control their pain with, we give pain medicine in case they want it, but most don't even have to take it. What is really helpful is ice. So like after the surgery, they have some variable degree of swelling, some bruising, and ice packs with like frozen peas, 30 minutes on, 30 minutes off for the first couple days. That works great and really controls the majority of pain. I also have them wear some pretty supportive underwear, and they're sore for somewhere between 2 to 4 weeks after the procedure. They're not in pain. They're able to sleep, and they're able to go to work and do kinds of things. Depending on the types of work they do, I'm okay with them going back to work within a week after surgery. And in terms of using the stem cells, I have not experimented with stem cells for this particular procedure. However, when I was at Pittsburgh, I did do some stem cell research on nerve regeneration and demonstrated some big effect on the nerve regeneration and the healing in that process from stem cells. Any other questions?
Came through. The question is, when can I have sex after surgery?
Oh yeah, great. So yeah, so then back to the penile therapy after the procedure. Once a patient has healed and they're not sore anymore, the name of the game is stimulation, as much stimulation as possible. Because what we're trying to do in that early postoperative period, say within the first like 6 months or so, is to remind the brain that there's a new route to send the information to the penis. And so how to do that is to keep stimulating the penis over and over again. So I tell my patients this all the time. You should be playing with yourself. It doesn't have to be anything major. It could just be like, light touch with your hand or with a feather or with a towel or whatever you want through the pants, just lots of stimulation. With a partner is even better. Whatever type of sex they want to do, whatever type of porn they want to look at, it doesn't matter to me. I don't care what it is what that gets them off. We just need to have some stimulation. And then as far as I'm concerned, I would hold off on having any like true sex for about a month. The reality is most of these patients don't get their erections back for several months. So it's kind of a long period for nerve recovery. Nerves in general take a long time to heal, a very, very slow healing. I tell my patients, don't expect anything super fruitful until 6 to 9 months after the surgery. That being said, my successful patients have some sign of change around 6 weeks. Around 6 weeks post-op, they don't get a full erection, but what they report back to me is they start noticing a change in the morning where they just feel different. They feel a little bit more engorged, a little bit more full, a little bit of a flutter, like just feel something a little bit more alive down in their penis. And from there, it progressively gets more and more and more until they can get up to a full erection. I have another question here. I'm a chemical tanker truck driver. Would I need more than a week off? No. For that, assuming that what you're doing is, sitting in the truck most of the time, I'm totally fine with that. The one type of activity that I'm worried about is guys that like play tennis or movements like that, because a movement such as a lunge laterally to widen your legs out, kind of spread your legs. That's the thing I'm kind of worried about in those first 4 weeks. So that's the one kind of restriction. So I wouldn't allow any sports for that first month. But going back to working as a truck driver, I don't see any problem with that at all. Any other questions, guys? Let's see what else. So the surgery the surgery takes about 2.5 to 3 hours. A nice thing about the procedure, although it's general anesthesia, I can't do a nerve block during this procedure like are done with like leg procedures. So I can't do that. I have to do general anesthesia because I have to keep all the nerves active. So while I'm doing my testing with EMG. So it's general anesthesia, but it's an outpatient procedure. So you go home the same day. So for my patients that are local, no problem. They, go back home, have someone drive them. For patients that are out of town, they can either go to a hotel if they have family member with them to take them there, or they can stay overnight in the hospital and then get discharged the next morning. But it is an outpatient procedure depending on if they're out of town or not. Any other questions, guys? Oh, good. Well, if you do have any more questions or if you want to have a formal consultation, I'd be happy to meet with you and discuss things further. Um, Thanks, guys, for coming in to listen about it. Okay. All right. Take care.
It looks like you got one more question.
Oh, one more question. Sorry. Oh, it's a great question. I'm glad you asked this. So have you been able to get this approved through insurance? Yes. So I had two international patients, they paid cash, but everybody else was paid through by insurance. I've had a little bit of pushback from insurance on two of my cases. And there was actually one patient that got totally denied and we weren't able to operate on him. But for all the other patients, insurance approved. We didn't charge anything else besides like the copay and deductible that you agree to. But yeah, it has been approved by insurance. Good question. All right, well, if that's it, we'll sign off, I guess. Thanks again, guys, and hopefully you found this informative.